All right, everyone, we're going to get started with our next session here. So as I mentioned earlier, I think we've had 2 very good days where we've all heard from each other, shared experiences, learned from each other. And I think one thing that Jess said yesterday really, resonated with me. And as an eye doctor, as an eye surgeon, of course, I love to save children's and people's eyes and sight, but I think we can all agree that even more so as an ocular oncologist myself and as families and parents of children with retinoblastoma, our goal is to save lives. And so that is why we decided to call our next session, We Can't Save Every Eye, but we can try to save every life. So we're going to hear about a number of ways that we can do this, a number of treatments, a number of experiences that can kind of help us work towards our goal. So I'm going to introduce our panelists, and then you guys can come up here if you want to, present from here or just stay there. So we have our very own Clayonia Colbert-Dorsey, who needs no introduction. She's our wonderful secretary. So she's the secretary for World Eye Cancer Hope USA. Then we have Dr. Furquan Shaikh, who is a staff oncologist for the Solid Tumor Program, Division of Hematology Oncology at the Hospital of Sick Children in Toronto. Then we're going to have a pre-recorded talk from Dr. Carol Shields, who I'm sure you all know, she's the Director of Ocular Oncology Service at Wills Eye Hospital. And because we have the wonderful Leia, who's her patient here, she's going to give her a little introduction before the pre-recorded talk. We have our very own Sandra Staffieri, also needs no introduction. She is the Retinoblastoma Care Coordinator at the Royal Children's Hospital in Melbourne, Australia, and also, of course, one of the scientific program co-chairs for this meeting. And finally, we have Dr. Christina Stathopoulos, who is a wonderful physician and dear friend of mine. She is an associate doctor at the Jules Gonon Eye Hospital in Lausanne, Switzerland, and she's the head of the pediatric ocular oncology unit there. Let's get started. We're going to have Clay first.
Thank you, Maura. Thank you, everyone here this morning. I am filled. I will say that first of all. And I have a stack of tissues. I told our USA team that I've been crying since first thing this morning. So I've been trying to be calm, cool, and collected and composing myself. I have a room full of family. They know that I am a crier. For those of you who have had the wonderful opportunity to attend One Retinoblastoma World conferences, you know that usually the last day is a day of crying anyway. And so I'm going to say it now. I just might start a little early. So please bear with me. So you all have heard that. Aloha. I am Clayonia, or you can call me Yonia, as my family and friends do, or Clay, Twavanette, Colbert, and my husband wants to make sure you have the Dorsey on the end of that, too. I want you, and the reason I wanted to stand up is because I want you to look at me. Twirl is my friend, my new brother, Mark Labash, sitting back there with his lovely wife. I thought that I was going to come into this conference and that I was going to be perhaps the oldest. Oh, wait, how can I make that sound positive, Mark? One of the seasoned survivors of the program. Because what we should not forget, there's a lot of emphasis on the young children and the parents and the perspectives that they bring and what they are going through. But as we all know, retinoblastoma is a cancer that stays with you for the lifespan. And so for those of you who are new to this journey, I represent, and I'd like Mark, please, to stand up. We represent what your children can live and thrive to be. Yes. And so it is important for us, as we're just making it the new terms, folks, okay? The new term is thrivers at every level need to be able to come together, to commune, to get strength from one another. That's what this program represents. And so that's what I'm here to represent. So as an elder, I have a little wisdom to share. Let me tell you, though, a little bit about my story. I was diagnosed, and this is going to help you guess, perhaps, like how old Mark and I may be, what neighborhood we may fall in. I was diagnosed in the mid-60s at the age of 2.5, when my mother was actually pregnant with my second sister. My middle sister Dana is here. My second sister Keisha is home with my mom, who's not able to travel due to health reasons. But Mom was well into her pregnancy. My dad is here. Mom couldn't be here, but my dad is here. Mom was into her pregnancy, and not only did she and my father get the shock of hearing that their firstborn child had cancer, they were in the middle of this pregnancy. A young family of color in a time of significant societal unrest, because that's what was happening in the 60s, with no family history of retinoblastoma, was faced with a challenge that would forever change their world and my life. My mother wanted to wait until my sister was born. You know, you can imagine that's really heavy to deal with. She's in the middle of a pregnancy. She's been told her child has cancer. She said, can we wait? Do we have to make these decisions now? And she was told that if we wait for this child that is growing inside of you to be born, then this child that you are holding on your lap will not be with us at the end of this pregnancy. The tumor that I had was growing inward to my brain, and my parents were told that it was very important that I be enucleated immediately. Enucleation, family, because that's what we are in this room, each and every one of us. Enucleation, family, was my survival. I sat in yesterday morning's session where we looked at pictures of beautiful children, of those babies on the African continent, Africa, the land where my ancestors were stolen from. And in that moment, I had an emotional storm. I sat here and I cried, because what washed over me was the fact that had my parents not made the decision that they made for my enucleation, I might have been like one of those children who was depicted in the pictures and who unfortunately are no longer with us. Enucleation has not, quite frankly, made my life any easier. In fact, in some respects, it has made my life harder. However, the journey is daily, and a lot of it is in my head. And we talked about that with our survivor panel on the first day, how perhaps we think and feel far too much. So I'm still to this day reflecting on my diagnosis, who I was before RB, and I was only 2.5, and I like to share with people, because I was 2.5 and a little bit older, I vividly remember I was treated at the Cleveland Clinic. I vividly remember being at the hospital, being in the playroom, being with the 2 roommates that I had. I think about those things before and after and ongoing. We've talked about how we as survivors look at ourselves. If we as survivors had an opportunity, particularly adult survivors, to come together, to reflect, to talk, to have open and honest discussions, I think that we would find that there are a number of commonalities in our journeys and what we've experienced and what we've gone through. In 2017, when I attended my first World RB conference, there was a adult panel, and as I sat and listened, I remember for those who were on that panel and them sharing their stories, I remember thinking, wow, the feelings of wondering how do we go on, and the feelings of getting through childhood, and the feelings of depression. Those were all feelings that at one time or another had resonated with me. Marissa, I'm gonna put out a plug, Marissa, Pamela were a powerful New York Times article that talked about Marissa's journey. And reading Marissa's story, I was like, yeah, I can totally relate to everything that she went through, everything that she's gone through. And I'm sure that a number of survivors can. How I look at myself is one of the things that I think about. How are other people looking at me is something that I think about. The need for not only consistent medical follow-up. As retinoblastoma survivors, we know that I say ours is a cancer that keeps on giving. Because even after the initial treatment, you know, you still have to have those ocularis visits, and we still have physical discomforts as we are living with whatever we're living with. It stays with us. We have to go through things that perhaps others don't have to deal with. So I recognize and I acknowledge that retinoblastoma may have changed my life, but I'm here to tell you that it did not take my life. I am here. I am still standing. I am not just surviving. 58 years past my diagnosis. But I am here as the new term we are going to champion moving forward further. I am here and I am thriving. I am here, family. I am here like the granddaughter of the Tuskegee Airmen that I am, who like wind rises on wings. I rise. I am life in its formal fashion. For the past 15 years, my work has been in the space of association and nonprofit management. And in 2019, I was nominated to the American Society of Association Executives Diversity Leadership Executive Program. It is a competitive 2-year fellowship that accepts only 12 people a year, and it's looking for candidates in underrepresented populations, those who may be in the LGBTQ+ space, or those who are differently abled. And I said, hey, I got this, because I'm black and I'm blind. So I got this. And I'm happy to say that, yes, I did get one of those 12 spots. Happy to say that I am a DELP scholar. But part of that application process was that you had to write an extensive application. And I think leaning into wanting to get into that program so badly and the prestige that is associated with that, even though I had started engaging more with We See Hope, I really began to own my story as a retinoblastoma survivor. And so in my essay, I coined a phrase. Y'all don't steal this because I'm going to put it on a T-shirt and I'm going to sell it one day. So I'm going to share it, but y'all don't steal it. The term that I coined was that life brings struggle, but struggle births hope. I'm going to say that again. Life brings struggle, but struggle births hope. So what I came by to tell you as we look at life after enucleation is that, family, there is hope in this room. An outcome from this year's conference, for me, is what we heard on Tuesday, and I'm going to say it again, and I'm going to encourage all of us to reflect on this, that we in this room, we've been calling ourselves survivors, but guess what? We are moving to thriving. We are moving to thriving. Yes, we're survivors, but it takes more to thrive, which speaks of the individual acceptance, courage, and resilience that is in each and every one of us in this room. So I'm going to say again, as the elder tasked with talking about life after enucleation, let me leave you with some final thoughts on what is enucleation. It is not the worst thing that has ever happened to me. Despite my circumstances and despite what I have been through, I know that I can do all things. I do not blame my parents for the difficult choice that they had to make. I would rather, and I do as I stand before you today, have life. And for that, I am so grateful. The sight that I do have, and I'm a unilateral survivor. I like my stylish glasses, y'all. And there was a question raised on day one about eyewear and protection, and my ocularist and my ophthalmologist have been very clear that I should be wearing glasses to protect that sight, because yes, I am partially blind, and my life and my sight is precious. Counseling and/or finding a support group, such as the groups that you have heard about today, and I'm on the board of directors for World Eye Cancer Hope USA, so I'm going to plug World Eye Cancer Hope USA. Finding that support is critical. To each and every one of us, and we heard this said earlier in the week, every one of us in this room, we are united by retinoblastoma. We are all family. When I walked into that conference room in DC in 2017, I had never in my life ever met anyone who had ever had retinoblastoma. That was a tough journey to feel like you were totally, completely by yourself in the whole world. And even though I have 20 plus family members with me, and it is a village, and my family loves me unconditionally, it's still not the same as not of knowing that I was different because of my experience and not having anybody else to talk to about it, to know that somebody had gone through similar experiences, until I found the family that here it comes. Until I found the family that I found in 2017. And the family that continues to endure as a result of this conference and what it means. And if this is your first conference, I hope that you will continue to join with us, that you will continue to be encouraged with us, that you will look to us and see us as resources. I challenge us to know that there is power in our coming together. And I challenge us to continue moving onward and upward. We are in Hawaii, but there's a South African greeting that I often use, and it is Ubuntu. I am because we are. And so now here's time for some audience participation. Who are we? We see hope. Who are we? Let's all say it. We see hope. I challenge you to believe what it is that we see hope stands for. That's life and sight for every child. We see hope. Thank each and every one of you for being here.
Thank you so much for this powerful talk, Clay. We're going to move on to the next speaker. Furquan, please.
I knew I didn't want to follow Clay. I can twirl, but I won't look as good. All right. Good morning, everyone. My name is Furquan Shaikh, and thank you to the organizers, especially to Sandra and Marissa, for inviting me today. This is my first 1RB World Conference, and I have to say the quality of the talks and the conversations has just been outstanding and so impressive. I'm going to talk about a review of high-risk pathology in retinoblastoma and what it means for treatment decision-making. And that may sound like a fairly sort of technical topic. I promise not to make it boring. And my hope is that it'll provide some of the background for many of the conversations and discussions that we'll have, and for the sort of the theme of the talk, which is we can't save every eye, but we can try to save every life. All right, so when one's diagnosed with retinoblastoma, there's sort of a lot of terms that exist in binaries. It's either exists in one state or the second, heritable or non-heritable, enucleation or eye salvage. And there's a sort of seemingly other binary term, which is intraocular, inside the eye, or extraocular, outside the eye. And these are two very different things, especially when it comes to treatment intensity and probability of survival and thrival. Extraocular, sometimes people mistakenly use the term, retinoblastoma as a good cancer, because if you see the statistics in developed nations, you might see 97, 98% cure rates and survival, but that's a bit of a misconception, because it's really the fact that the sclera is such a good capsule, such a good container, that it can, with early enough presentation, keep the tumor inside the eye. And that's why we talk about early detection and moving that detection spectrum from the bottom to the top row. But once retinoblastoma is extraocular, once it's outside the eye, it's really no better than any other metastatic solid tumor in terms of its treatment intensity or its cure outcomes. And so we want to keep retinoblastoma inside the eye. But this is a bit of a false binary, because in fact there's something in between. And what I mean by that is that, historically, clinicians and scientists saw that there's some children with retinoblastoma who appear to have intraocular disease, but behave as if they have extraocular disease, which is that a portion of them about 6 months, 12 months later would recur with metastatic disease, either in the central nervous system or the bone marrow, etc. And so when they tried to look into why that was, they discovered this thing that we now call high-risk pathology. Looking at the layers of the eye, they said there's some clues at a microscopic level within either the choroid, the optic nerve, or the sclera that tells us what's going on here. And so if you have a retinoblastoma that, even at a microscopic level, is extending into the optic nerve beyond this line called the lamina, then that can be associated with an increased risk of recurrence in the central nervous system. If the retinoblastoma extends into the choroid, which is the blood vessel layer of the eye, then those cancer cells can hitch a ride on the blood vessels and end up implanting themselves in the bone marrow, the bones, or the liver, and show up months later as a metastatic recurrence. And if the retinoblastoma cells track through the layers of the sclera, they could potentially contaminate the wall of the orbit and show up down the road as an orbital recurrence. And so this was termed high-risk pathology. It's perhaps better thought of almost as high-risk extension on an enucleated eyes pathology. And so although its definition varies, and even sometimes us clinicians can't agree on the perfect definition, at a high level it means one of these three things: either massive, more than 3 millimeter choroidal invasion, optic nerve infiltration beyond the line of the lamina, or a transscleral extension. And as I've already alluded to, each one of these comes with a different risk for the high-risk pathology. So involvement of the choroid can portend a bone or marrow relapse. A sclera can be associated with an orbital relapse. An optic nerve can be associated with a brain relapse. And so now we know what high-risk pathology is. We can ask, or we probably want to ask, three important questions. Number one, how common is it? And if it's present, how high exactly is the risk of metastases? And if metastases are present, how high exactly is the chance of cure or non-cure with those metastases? And I hope you can see that these three questions are almost kind of like three different filters that you could go through and come up with an ultimate percentage. And so we know the answers to these fairly well. How common is high-risk pathology among enucleated eyes? There was a study done by Dr. Barrios as part of a children's oncology group trial where they looked at 321 enucleated eyes and found about 29% with high-risk pathology. Similarly, there was a study done by Dr. Tumor with an international database of 942 enucleated eyes, and almost exactly the same estimate, about 30% showed high-risk pathology. So we can say that among eyes that are advanced enough to need enucleation and have undergone enucleation, high-risk pathology will be seen in just about 30%. So what does, however, high-risk pathology is a bit of a circular problem as well, because you want to know high-risk pathology to help you decide on enucleation, but you need enucleation to know if there's high-risk pathology. So the question is, can you sort of make best guesses on who would have high-risk pathology? And the same study that I mentioned by Dr. Tumor and some people in this room are on this paper looked at certain predictive risk factors that could be identified before enucleation just by examining the patient. And certain features such as new vessel formation, increased pressure, bleeding, inflammation, size over 2/3 of the globe, or diffuse infiltration were all led to increased chances of finding high-risk pathology, anywhere from 2 to 4 times. And next question, if you have high-risk pathology, what is the risk of metastatic relapse? This is a study by Dr. Honava together with Dr. Shields' group, and he saw that among patients in their cohort who did not have chemotherapy after enucleation, the risk of recurrence was about 25%. But subsequent to this, they began treating their patients with high-risk pathology with adjuvant, meaning after surgery chemotherapy, and found the risk of recurrence was about 4%. The paper I alluded to by Dr. Barrios, the COG study, also gave chemotherapy to all their patients, and the recurrence rate was, again, 4%. And this is a busy slide, but just shows there's been more than about 15 publications showing patients with enucleated high-risk pathology who've gotten chemo. The total percent of metastatic recurrence was 9%, but if you filter that down to newer studies that use platinum chemo, it also settles right around 4%. And if someone gets metastatic retinoblastoma, what is the chance of cure? And this is, of course, a depressing slide. So for stage 4A disease, those who have bone or bone marrow metastases, the chance of cure on the most recent publication by Dr. Ira Dunkel, again from a COG trial, was about 80%. But for those with stage 4B or CNS metastases, it was only about 10%. And because both of these are about similar in incidence, the average survival is probably somewhere in the middle, around 50%. So as I said, you can take these three numbers and put them through sort of subsequent, Swiss cheese, and you will come up with math that looks something like this. So imagine you have 100 patients in a clinic or in a center over time with advanced intraocular retinoblastoma. We know about 30 of them will have high-risk pathology. If we don't treat with something that provides systemic control, about 25% of those 30, so right around 7.5, or you can, since there's no such thing as half a patient, we can say 7 to 8, will develop metastases if untreated. And about half of those, so about 3 to 4, will die of metastases. And to some extent, this helps you see why even in advanced nations with early detection and excellent treatment, your cure rates are right around sort of 97, your survival from retinoblastoma is about 97, 98%. It doesn't reach 100%. We still are not saving every life. But here's a bit of a thought experiment. So imagine 3 different centers or 3 different nations that treat all patients with only one method. So either enucleation for all, IAC for all, systemic chemo for all. In the patients treated with enucleation, every child gets enucleated. 30 of them will have high-risk pathology, but we'll know all 30 of them. They can then be treated with adjuvant chemotherapy. So you'll get the lowest rate of deaths, 0 to 1 deaths, a lot of chemo exposures, but 100 enucleations. If you give IAC for all, then again, you'll have those 30 with high-risk pathology, but you won't know who had the high-risk pathology. Hypothetically then, about 7 or 8 of them could recur with metastases, and some of them would not be cured. So there would be the lowest rate of enucleation, but the highest percentage of death in that group. If you gave everyone systemic chemo, you again would have 30 high-risk pathology. They would be unknown, but they would be pre-treated without enucleation. But again, some of them would not be cured of their disease, so you would have 100 patients with chemo exposure and about 40 enucleations. What that thought experiment sort of tells you is that what you really need is the right treatment for the right patient at the right time. It tells you that some RB patients are best treated with enucleation. When eye salvage is attempted, some patients are best treated with systemic chemotherapy. IC is a great tool when used for the right patient, but it does not provide systemic control, and so judicious selection is very important. So let's go through that thought experiment one more time with one sort of new thing added, which hopefully will be here in the near future, and that is a better risk prediction model. And that can be the combination of the clinical risk factors that we just talked about, the improved imaging technologies that you've heard about, the improved molecular cell-free DNA techniques that we've all heard about. If you put all of those together in a risk prediction model that every patient goes through, then instead of saying that you have a 30% chance of having high-risk pathology, you could imagine a group of patients that have a higher risk. Let's say you have 40 patients with a 70% risk of high-risk pathology, then there would be 28 patients with high-risk pathology in that group. And then on the other hand, you have 60 patients with just a 3% risk of high-risk pathology, so you would only have 2 out of the 30 patients in this group. Those 40 patients could then be offered enucleation or systemic chemotherapy. You could hypothetically imagine that 50% of them would be enucleated, but the rate of metastases would be 4% of 28 because they would be treated with chemo, which is just about 1. And let's say they are successful in their treatment, there would be 0 deaths. On the other hand, the 2 patients with high-risk pathology in this cohort would not receive systemic chemotherapy, but they would have a 25% of recurrence of those 2 patients, which is a quarter. A half. And again, let's hope that the patient with improved treatment for stage 4B disease would not suffer end of life and would be cured. And so with this sort of hypothetical paradigm for the future, I think the conclusion we can make is that we can't save every eye, but we could try to save every life. Thank you.
Thank you so much. That was excellent. So we're going to hold on for the questions until the end. We have a pre-recorded talk from Dr. Carol Shields, but in the meantime, I would like to invite Leah to give her a little introduction. As you all know, Leah is one of Dr. Carol's patients. So while we bring up the recorded talk, Leah, go ahead. Thank you.
Hello. I am so honored today to be up here and to introduce someone who is so dear to my heart, to my family's heart, and to many of you here in the audience. Dr. Carol Shields, she is a mom to 7 amazing kids and also 1 new grandbaby. Did you know she played D1 basketball at the University of Notre Dame? She's a superstar, not only in the medical field, but her personal field. One of my key memories I have of her is her youngest daughter is my age, and every day after work, they would get on scooters and they would ride around their neighborhood and then lay in the grass and look at the stars. So as busy as she was in the medical world, the priority of her family was still at an ultimate high. Dr. Carol Shields is a leading doctor, researcher, mentor, educator, and everything in between in the retinoblastoma world and with other eye diseases. Although she could not be here today, I would like to give a warm welcome to Dr. Carol Shields.
Hello, my name is Carol Shields. I have no financial interest or relationships to disclose, and I'd like to talk to you about adverse reaction controversies in ophthalmology. And one controversy was chemotherapy for retinoblastoma. Does it even work? Now I'm talking about historical ocular oncology. From protest to success. Let me explain to you. Back when we started chemotherapy in the early 1990s, we heard various comments like, chemotherapy does not work for retinoblastoma, why use it? Or, don't touch vitreous seeds, that can seed the orbit. Or if you have vitreous seeds or aqueous seeds, you must do urgent enucleation. Chemotherapy will only be temporary. And one quote from a very prominent ophthalmologist was, chemotherapy will lead to tumor recurrence and possibly patient death. And that ophthalmologist even warned me that, Carol Shields, you could be killing children. I was nervous about this. Well, in the 1950s, yeah, chemotherapy did not work. for retinoblastoma. Same in the 60s, the 70s, and the 80s. The regimens that we were using was not effective. But back in the 90s, the early 1990s, we found a regimen that worked. Credit to Dr. Judith Kingston at St. Bart's Hospital in London. She had a good idea. At St. Bart's, Judy Kingston, who had amazing dedication to her retinoblastoma patients, and she was working with John Hungerford, a consultant in retinoblastoma. And at this time, treatment of retinoblastoma was largely confined to surgical treatment like enucleation or radiotherapy, like external beam radiotherapy, and I practiced during this era. But Judy's knowledge and understanding of chemotherapy for children led to an important discovery. She applied a chemotherapy that she routinely used for neuroblastoma to retinoblastoma. Just 2 cycles, and it worked, 1994. And then later, we modified it to 6 cycles, and it worked permanently in most kids. This was such an important discovery that in 2021, 27 years later, I wrote an editorial with Jerry Shields to the Asia Pacific Journal of Ophthalmology entitled, "Here Comes the Sun for Retinoblastoma." In it, I indicated that Judith Kingston was a pioneer of chemotherapy for retinoblastoma, and may she never be forgotten for what she did for this field. And her collaborator, John Hungerford, a retinoblastoma expert, he credited Judy Kingston's contribution and said, "This has been paramount to the current worldwide treatment of this tumor in thousands of children." Here comes the sun for retinoblastoma. Things totally changed from the 1990s to current. Chemotherapy for retinoblastoma revolutionized care. More lives and eyes saved than ever. Minimal toxicity available in all continents. It's practical. I think it's the single most important discovery in the retinoblastoma world thus far. So we use chemotherapy in intravenous delivery for bilateral retinoblastoma, in intraarterial delivery for unilateral retinoblastoma. We inject the vitreous for vitreous seeds and the aqueous for aqueous seeds. It's fairly non-toxic, no second cancers related to the chemotherapy, and it can reverse cancer. So if we look at a timeline, it was 1994 that intravenous chemotherapy was introduced. And then 4 reports came out in the journal Archives of Ophthalmology. One from Judy Kingston in London, Brenda Galley in Toronto, Carol Shields in Philadelphia, and Lynn Murphy in Los Angeles, with an editorial written entitled "A New Era for the Treatment of Retinoblastoma" by Rick Ferris and Emily Chu. We all outlined our success and failures with intravenous chemotherapy for retinoblastoma, but now we have 30 years follow-up. And I'd like to thank publicly Dan Albert, the editor of Archives of Ophthalmology, in 1996, because he published these 4 articles and the editorial, this paradigm shift in the way we manage retinoblastoma. Of course, I submitted our work promptly, and Dan asked me to wait for the other 3 centers to submit their work. So I waited 1 full year with all that good data, and we published all 4 reports together in the same issue. It was an amazing issue, and it was an honor to be a part of this history and this momentous ophthalmologic issue. So the management of retinoblastoma has changed from enucleation, external beam radiation, and plaque radiotherapy to chemotherapy. So the current management is all about chemotherapy. Here's some of our results, 25 years follow-up, before and after intravenous chemotherapy with consolidation Another eye, before and after, no consolidation. And another eye that showed the reality. Yes, you can get tumor regression, but it can become recurrent. And in those cases, you have to go on to either further intravenous, intraarterial chemotherapy, or plaque radiotherapy. And here's one case in 1994, just when we were starting intravenous chemotherapy. We had a bilateral group D retinoblastoma in a young girl from Florida. Total retinal detachment in both eyes. I did not know how this was going to turn out. And here she is, 30 years old. Her vision is now 20/30 in the right eye, 20/70 in the left eye, no metastatic disease, both eyes saved with decent vision. So let's fast forward to 20 years. Is there still good tumor control? Like, is this intravenous chemotherapy lasting forever? Well, we did this. We did a research protocol on long-term 20-year real-world outcomes of intravenous chemotherapy for retinoblastoma in almost 1,000 eyes of over 500 patients, published in the BJO 2020. And what did we find? Well, divided by groups A, B, C, D, and E, we found at 1 year we had excellent control in A, B, C, and even D, and intermediate control for group E, 47% of globes saved, whereas A, B, and C had over 93% of globes saved. And that persisted in 2 years, 3 years, even at 5 years, 10 years, 20 years, even though we only gave 6 months of chemotherapy. This lasted with complete control up to 20 years. So basically what we saw at 2 to 3 years lasted for 10 to 20 years. So yes, in answer to that question, it is lasting at 20 years. But the caveat is you might need to be creative in your work because you might have to add on other treatments in case there is recurrence. For example, the need for intraarterial chemotherapy or plaque radiotherapy, IAC in blue, plaque in green. You can see that some patients will need these additional therapies. We usually start with IAC, and if that fails, go on to plaque. So overall, about 17 to 19% of children who get intravenous chemotherapy need IAC or plaque radiotherapy additionally for globe control. How often do we need intravitreous chemotherapy? I think you're going to be surprised when you see this. 10% or less. We don't need it that often. When we're giving systemic chemotherapy, that chemotherapy gets into the vitreous and our need for intravitreal chemotherapy is low, 9 to 10% or less. Now, what about IAC for retinoblastoma, used mostly for unilateral cases? Well, our program started in 2008, so we now have 16 years follow-up. We have 2 full-time neurosurgeons who perform the catheterization. They never pass the case, they do their own work. And this is why we have such good results. They catheterize up to the ophthalmic artery ostium without entering, inject the chemotherapy into the eye, and you can see before and after. No consolidation. This patient only received 2 doses of melphalan with good control. Here's another one with group D exophytic retinoblastoma with subretinal fluid before and after, 3 doses of melphalan, no consolidation. Do we ever consolidate after IAC? And the answer is never. We never consolidate. Why not? You don't need to. And it produces retinal necrosis at the site that you treat, and you're going to get visual field defects. So in answer to all these protests, chemotherapy does not work for retinoblastoma. Chemotherapy will lead to tumor recurrence and possibly patient death. Not right. Those protests were wrong. And thanks to Dr. Judith Kingston. She passed away, unfortunately, in 2016. She never sought the limelight nor recognition for her work. The only reward that she wanted was the recovery of the children she treated. She teamed up with John Hungerford. Their joint collaboration marked a revolution in the way retinoblastoma was perceived and now treated. Her pioneering work transformed the lives of so many retinoblastoma babies and their families. So in June 2015, at the International Society of Ocular Oncology, just 7 months before she died, I publicly thanked Judy Kingston for her recognition of chemotherapy for retinoblastoma, and I told her story. She received a standing ovation at that meeting. May she never be forgotten for her contributions to retinoblastoma. Courage, hope, desire, and a good idea was the perfect combination. So in conclusion, management of retinoblastoma with primary intravenous chemotherapy at 20 years is excellent. Groups A, B, and C have 90% control with globe salvage or better. This is thanks to the pioneering work of Kingston, Galley, Murphy, and Shields. And then IAC for retinoblastoma, thanks to Kaneko, Abramson, Hagestinolau from Italy, and Shields. Primary IAC at 5-year follow-up provides 100% control with globe salvage for groups B and C in our hands, almost 90% control for group D, and about over 50% control for group E, but you may need to use additional therapies of intravitreous chemotherapy in those cases. So in answer to this adverse reaction, chemotherapy does not work for retinoblastoma, I have to say that's wrong. Chemotherapy for retinoblastoma really works, and all of us have seen this in action. Thank you.
We'll move on to our next speaker, Sandra.
Thank you very much. That's a tough act to follow. Oh, cool, got my slides. I'm presenting this work on behalf of my colleagues at the Children's Hospital, and I thank Dr. Lily Rolfe, who's just got on the ophthalmology training program, who performed all the data collection and analysis and understood our vision. I'd also like to acknowledge this study was funded by the inaugural Professor Frank Bilson Research Scholarship. You're all aware of the various treatment modalities that can be used for retinoblastoma, either in isolation or in combination. And there are many factors that contribute to treatment decision-making, including whether one or both eyes are affected, the extent of the disease, so the classification and staging, and whether any vision might be preserved. All this with the treatment goal being saving life as the first and main priority. At the time of diagnosis, when there is heightened stress and distress, as clinicians, we give caregivers a crash course in ophthalmology and send them to our oncology colleagues for a crash course in oncology and expect them to make an informed decision about their child's treatment quickly, because time is of the essence to achieve the desired treatment goals. In our centre, we have used IAC for more than 13 years, but it has only been in the last 5 or 6 years that we have used it as a primary treatment. I did a quick calculation the other day, and I have supported families over more than 120 of these discussions, and I realise the decision-making is not easy, and what you go through as parents is not lost on me. Parents make the best decision they can with the information they have and understand at the time they're being asked to make that decision. Understanding the treatment includes understanding the journey they're going to have to go through to receive that treatment, and that is the impact of that treatment choice. To be able to do this better, our group wished to compare the treatment burden for children with unilateral retinoblastoma, specifically children with no family history, with primary enucleation or primary eye-saving treatment. There were 60 children that met the inclusion criteria for the study, and they had an average follow-up of around 96 months. Now, this pie chart reports the number of children in each group. Remembering, I'm from a small centre and I don't see a lot of patients per year, so it's very hard to do robust research with lots of numbers, but in any case, there were 70% of children that had enucleation as a primary treatment, 17% had an enucleation and additional systemic chemotherapy for high-risk pathology that Furquan so beautifully explained. 10% had primary systemic chemotherapy and focal therapy or consolidation, and 3% had intra-arterial chemo. We counted the total number of general anaesthetics for any procedures directly related to their RB diagnosis, EUAs, enucleation, port insertions and removals, MRIs, their labs, etc. I would like you to note that where possible, I try very, very hard to coordinate multiple procedures under the same general anaesthetic, an EUA with an MRI or an EUA with a prosthetic fitting. This table outlines the demographic characteristics of the patients included in the study. Children who had an enucleation, irrespective of the need for additional systemic chemotherapy, were on average the same age of 24 months or 2 years. The 6 children who had systemic chemotherapy had an average age of around 32 months, whilst the children who had IAC were a little younger at an average age of 17 months. As I said, our numbers are smaller in all the groups except primary enucleation alone, and this could explain why there's no real statistical difference. Genetic testing was able to confirm non-heritable RB in a total of 27 children who had an enucleation, whilst heritable RB was found in 4 children who had other treatments. There were some children where genetic testing was not fully informative and would have had regular surveillance with EUA until they were old enough to do these examinations awake, which is usually around 4 years of age. This table shows the size of the tumour and classification within each treatment group, and as you can see, the size of the tumour was about the same across the board, but the classification and staging was not. Notably, most of the children having a primary enucleation had a group EI using the Shields classification or the ICRB. This very busy table includes the most salient and statistically significant parameter. In the first 12 months of commencing treatment, children in the enucleation-only group had an average of around 5 total general anaesthetics, compared to 10 for children in the enucleation and systemic chemotherapy group, and 14.5 for those who just had systemic chemo and consolidation, and 15 for those who had intra-arterial. Children treated with enucleation had an average of 9.5 visits, hospital visits, whilst the children in enucleation and chemotherapy group had 34. The chemotherapy group alone had 41, and the intra-arterial group had 24. These differences were statistically significant. So from these data, we've now collected it and proven it, we can confirm that treatment to save an eye has a significant impact on the number of invasive treatments and hospital visits. As I said, because we have a low number of patients by virtue of where I live, of course there are some caveats to the conclusions that we've reached. The younger the child, the more EUAs they will require to monitor any new disease if we don't have conclusive genetics, or if their eye is salvaged. They will naturally require longer follow-up, since examining a 2-year-old reliably is harder than a 4-year-old, and we don't want to be missing the relapses. In my centre, I do my level best to combine multiple short procedures to reduce admissions and anaesthetic inductions, and we certainly need more studies looking at vision outcome. This study has enabled us to provide parents with an idea of the actual burden of the treatment pathways they need to choose between when there is a safe choice to make. And this information, I believe, helps them make an informed decision for their child and their family. We do need more data for our patients with intra-arterial, as they naturally require fewer oncology appointments. But what do we need to know next? We know a little bit, but there's so much more that we need to find out. We need to understand the lived experience for the different treatment pathways. What is the psychosocial impact of so many invasive interventions on the young child, that child as a teen, that child as an adult, and let us not forget the parents who had to make that decision. And we also need to understand the burden of treatment by enucleation, again through the eyes of that child, that teen, that young adult, and also the experience of the parent who makes that life-changing decision for their child. The hardest thing I believe about being a parent is making decisions on behalf of your child. But knowledge is power, and we've been using this data for a short while now to provide parents with a realistic idea of what eye-saving treatment might really look like in the truest sense for them. Thank you.
And last but not least, Dr. Christina Sifopoulos.
Good morning, everyone. Thank you very much to the organization for allowing me to be in this very unique meeting for me with the possibility to interact with the families. So I'm going to talk about conservative eye-preserving treatment in retinoblastoma. We are going to go through together what weapons we have to fight the cancer when it's located exclusively inside the eye. But first of all, I would like to remember that every decision we take for our patients, we try first to save the life, then to save the eye, and finally to preserve the vision. And this has been true for more than 100 years of conservative treatment in retinoblastoma. So what can we use for retinoblastoma? We can use chemotherapy, we can use also focal treatments. Often we have to use a lot of weapons to reach our goals, and often there are different ways to reach our goals. How do we choose? Well, it depends a lot on the extent of the tumor at diagnosis. As you know, the tumor starts growing inside the retina. But if it is not treated, it can grow. Cells can detach from the main tumor and go and invade other places in the eye, either under the retina, they can spread also inside the eye, or even in the front of the eye. So, do all children need chemotherapy? The answer is no. When the tumor is catched very early, focal treatments such as different kind of laser can be enough to treat the patient. And you see here an invisible tumor in a screening patient with a familial retinoblastoma. The tumor is only visible with the OCT, the machine that helps us with a higher resolution to see things we cannot see with the eye. And this child was treated only with laser. This is another kind of laser called thermotherapy to reach a tumor which was a little bit bigger, but again, this child didn't need other chemotherapy or chemotherapy at all in his treatment. Cryotherapy, you are also aware of treatment of small tumors by the cold. So, when the tumor is bigger, then we have to give chemotherapy. As Dr. Shields pointed out, systemic chemotherapy still has its place in the retinoblastoma treatment for advanced bilateral cases, for cases which are too young to have safely intra-arterial chemotherapy, but also in places where IAC is not available. Usually, it's also combined with focal treatments. the video, I don't know. Yes, oops, sorry. Intra-arterial chemotherapy, yes. It allows us to give a very high toxic dose of the drug directly into the vessels that irrigate the eye. It works very well for the tumor when it's in the retina or in the subretinal space. It doesn't work so well when the tumor is in the vitreous. The vitreous is the inside of the eye. In that place, there are no vessels, so the chemotherapy doesn't reach high concentrations enough. ICs helps to salvage very advanced eyes that were previously enucleated, such as this eye, and you see under the second picture that not only IC was given, but additional treatment to reach success. Here you have an example of a subretinal seeding, the whitish areas on the left that disappeared completely after one IC. It's a case of relapse. And it has allowed to salvage eyes with advanced disease with a significantly higher rate than intravenous chemotherapy. And that with a faster way, less treatments and less side effects, without jeopardizing the overall survival, which is also very important. However, we have to be aware that there can be complication intraocular of the treatment. One of those which is feared is what we call the choroidal ischemia. This is an irreversible complication that can go and lead to totally vision loss. 5% of the procedure, even if they appear to have been done without any problem, can have such complications, and the parents should be aware of it. Other complications, such as permanent retinal detachment, can also occur after IAC, or ischemia leading to bleeding in the eye and loss of tumor control. And those are complications that can be treated. As I said, when the disease is in the gel inside the eye, then we do intravitreal injections. The safety-enhanced technique has allowed to treat eyes with such a totally invaded cavity with the seeds, and that without jeopardizing also the survival. There are no extraocular seeding, so spread of the disease outside the eye if the injection is performed according to the safety techniques. Now, when the disease comes in the front of the eye, there is intracameral injections. It's a type of injections directly into the eye in the anterior segment. Again, it allows to salvage very diseased eyes. Here we have a case. It was the only remaining eye of a 2.5-year-old boy with a massive invasion of the anterior segment, where ICC, along with other treatments, allowed to salvage the eye. Our experience in Lausanne with such eyes has also shown that it doesn't jeopardize, this treatment doesn't jeopardize the overall survival. So the improvement in the treatment with targeted chemotherapy, chemotherapy, intra-arterial and intraocular injections have improved the globe salvage without jeopardizing the survival, and also very importantly, they have allowed to eradicate the need of irradiation. You know that it causes bone deformation to irradiate a growing bone of a baby, and it's also associated to secondary cancer. So is there still place for enucleation? The answer is yes. At diagnosis when the disease is too extended, and also during the treatment sometimes for treatment resistance or treatment progression. Do we know who is going to be treatment resistant or who will not be able to keep his eye at the beginning? No, we don't know it yet. I give you that example. It's 2 unilateral diseases on the left in a 5-year-old girl, on the right in a 2-year-old girl. The girl on the left with a group E did actually good with few treatments. She recovered 100% vision, and we now have an almost 5-year tumor-free follow-up. The girl with group D, which was a group less advanced than the other girl, initially she did well, but finally she recurred and she needed to be enucleated. The answer to that, this illustrates that there is still a lot to understand on how the disease evolves, and new treatments have also need to be found. One answer, the answers will be answered by the liquid biopsy analysis, as Dr. Jessie Berry explained in depth yesterday. And finally, just to remember that retinoblastoma survivors that have kept their eye need to be lifelong follow-up. That for diagnosis of late relapses, it's something that can occur, and also for the treatment complications such as cataract, retinal detachment, or neovascularization, bleeding in the eyes. With that, I would like to acknowledge with this diapositive the teamwork that is done. Of course, you know that it needs efforts from a lot of people to treat patients with retinoblastoma. I would like also to thank the parents. I hope you know that you give us the strength to fight every day, and the faith that you have in us make us want to give the best of us. Thank you very much for your attention.
Thank you all so much for such amazing talks. I know we are short on time, and I know we have an amazing keynote coming up. I wonder if we have time maybe for 1 or 2 questions, max. I see Jess coming up on the microphone.
That was amazing. That was an amazing panel. I took pictures of all of your slides, and they're all already on Instagram. But like, I was cheering the whole time. Can you put that slide up, please? You all gave really good talks, but I thought this slide was really important. Yeah. Really important. If you haven't taken a picture of this slide, take a picture of this slide. I hope it's okay if everyone shares this on Instagram. Okay, because I'm going to be the person that asks tongue-in-cheek questions that don't have an answer. Where's Lori? How come Facebook says that's not true? Right? How come Facebook says that systemic chemotherapy should never be given for any child with retinoblastoma, but all these experts say it's a life-saving treatment and it decreases the rate of metastatic disease and probably decreases the rate of pinealoblastoma, which is also a deadly diagnosis, but rare of rare? But how come Facebook, where there are no medical doctors, disagrees? I'll let you guys answer. I'm not the one to answer that because I'm not on this Facebook group, but and it plays a really important role, but in medical decision-making, I think it should not. But this is the slide that every doctor needs to discuss with every family, because there's a role for all 3 of those treatments. And if we use biomarkers, of course I'm biased, but if we use biomarkers and we apply them correctly, then maybe we can aim to save every life, even if we don't save every eye. You guys are rock stars. Thank you.
I just want to, I'm going to make a super quick comment to piggyback on what Jess just said. There's nothing that's like 100% always for everybody in medicine. So to Furquan's point, there's a right treatment for the right patient at the right time. So nothing is 100%. It's not one size fits all. Next question, please.
Yeah, hi. I'm Mark Lubash. Clay, she kind of introduced me. A lot of brilliant stuff that I heard, a lot of very technical stuff, and just incredibly advancements. And as she pointed out, I'm a 63-year survivor, not 63-year-old, 63-year-old survivor. So long time. And little applause. Yeah, that's what I was going to get to. So I've met so many people here that have young kids here, and when they hear my story or heard Clay's stories, it's like, I see them, their hands going like praying only. So, Clay, have a cry or two. So just to those people, there is hope, and the hope is just look at Clay and look at me, who's, like I said, long survivors. The other thing that, Clay, that you said that I thought was really wonderful, I mean, look, everybody has challenges in life, but the thing that I got from your talk was that you don't have limits. And your kids and young survivors, you don't have limits. You may have challenges, that's different than having limits. So anyway, thank you, everybody.
Hi, I'm Helene. I'm 47 again. Just real quick, I'm not sure if this is the right panel to talk to, but in my 30s, I developed radiation retinopathy, and there are limited treatments because there's not a lot of studies for the radiation effects, so I'm treated with drugs for diabetic retinopathy. I'm just curious if any of you, how involved are the retinoblastoma specialists with follow-up care for the long-term stuff that my retina specialist is trying to figure out for me?
So maybe I can speak to that. We have a lot of that when we treat our adult patients that have melanoma, a lot of them, because they get much higher dose radiation, because it's a more radio-resistant tumor, they get radiation retinopathy. So we deal with that a lot. Those are the medications that we're using. It seems that radiation retinopathy, from a physiopathologic standpoint, is pretty similar to diabetic retinopathy, therefore kind of the association there. But to your point, there is a clinical trial, prospective, finally, coming up, just started. I think they're enrolling already. The DRCR network is a network that looks at retinal diseases specifically. There's something that's now called Protocol AL, where they're gonna pretty much look at observation versus using one of the drugs that are used for diabetes called faricimab and steroids prospectively. So prospectively, and it's gonna look at prophylaxis. So should we start treating patients before they even develop radiation retinopathy? How long do we have to treat patients with what medication? So finally, there's work being done in that area. I think we're going to have very significant information coming from that study. It's going to take a little bit of time, but we're working on that. So.
And I guess as a follow-up is, how do we make ourselves as long-term survivors more accessible to those of you doing research?
Yeah, so that is a wonderful question, and I think talk to your doctor, tell them that you're willing to participate in clinical trials to make your experience available to others, because that's really what moves the field forward. So, yeah, thank you all so much for an amazing panel. Sorry for going over time, but thanks so much.